to the AMIOCAT study, recurrence of arrhythmia following short-term oral AMIOdarone after catheter ablation for atrial fibrillation. Dr. Stine Darkner.
Good morning. I'm going to present some of the results from the AMIOCAT trial. And the AMIOCAT trial was an investigator-initiated trial that looked at short-term AMIOdarone following catheter ablation for atrial fibrillation. I have no disclosures. So patients undergoing catheter ablation for atrial fibrillation quite often experience arrhythmias within the first few months following the ablation. The ablation itself is thought to cause some of these early arrhythmias, and it can be a discouraging experience for the patients. The effect of preventing early arrhythmias with antiarrhythmic drugs after ablation is unclear. Although treatment with antiarrhythmic drugs has been clinical practice in some ablation centers, there are no guideline recommendations on this subject. AMIOdarone is considered the most effective antiarrhythmic drug to control AF. And based on these background informations, we aim to investigate whether short-term AMIOdarone treatment after ablation for atrial fibrillation could improve later success of the ablation. The AMIOCAT trial included patients planned for ablation of atrial fibrillation of paroxysmal or persistent type. In total, 212 patients were randomized. They had a median age of 61 years. And following catheter ablation, patients were randomized to either 8 weeks of AMIOdarone treatment or matched placebo. And patients were followed for 6 months, and we had a 3 months blanking period. And a blanking period following ablation is a period of time where patients can experience transient arrhythmias, which are not considered failure of the ablation treatment. For the primary endpoint, we looked at freedom from atrial arrhythmias at 6-month follow-up, and as you can see from this figure, we found no statistically significant difference between the placebo and the AMIOdarone group. For the secondary endpoints, we looked at atrial fibrillation-related hospitalizations and cardioversions within the first 3 months following the ablation. And this plot displays the hospitalizations and cardioversions rates for the AMIOdarone group compared to placebo. And as it shows, these were significantly lower for the AMIOdarone group. And when dividing patients into subgroups of paroxysmal and persistent AF, this was only significant for the group of persistent AF patients. So just to summarize the results, short-term AMIOdarone following ablation for atrial fibrillation, it did not improve success after ablation at 6-month follow-up. AMIOdarone did, however, reduce arrhythmia-related hospitalizations and cardioversions within the first few months following ablation, and this effect was more pronounced in patients with a history of longer episodes of atrial fibrillation. We considered the treatment to be safe and found no difference in the number of serious adverse events between the two treatment groups. We did see more transient adverse events and side effects in the AMIOdarone group, but we found no difference in patients' quality of life. So just to conclude on the results of the AMIOCAT trial, short-term AMIOdarone should maybe not be standard treatment after ablation, but should be considered in patients with persistent AF, which is longer periods of AF, enabled to prevent arrhythmia-related hospitalizations and cardioversions within the first 3 months following ablation. Thank you.
Thank you, Dr. Darkner, for that. Can you help us with the apparent paradox whereby at 6 months the primary endpoint, freedom from arrhythmias, was not different.
No. Well, we should of course take into account that we looked after a rather big reduction in recurrence rates. So the results of the study is of course limited by the sample size.
Sure. But help me with the difference between what you saw at 6 months and the impact in your second results slide in terms of hospitalizations.
Yeah.
So there seems to be a paradox.
Well, we did see also, it's not presented here, but also in the Holter monitorings we performed at 8 weeks following the ablation, we did see a significant reduction in the AF burden. And even though we did see that and a reduction in AF-related hospitalization and cardioversions, we did not see any difference at 6-month follow-up.
Okay, thank you. So open for questions.
Can you bring the mic?
Oh, sorry, the gentleman at the back was first.
Yeah.
Yes?
Which dose did you use it? Which protocol for AMIOdarone?
We were inspired from a trial from the 90s called the AMIOCAT trial. And for the first 2 weeks, the patients received 800 milligrams daily. And then for the next 2 weeks, 400 milligrams daily. And for the last 4 weeks, 200 milligrams daily.
So really, they were very adequately loaded.
Yeah,
Okay.
I would say so.
Paulus?
I just have a comment.
This is Paulus Kirchhoff, one of the experts.
Paulus Kirchhoff, one of the ESC spokespersons. And I think one of the patterns that emerges from your interesting and important study and from START AF2 is that I think we have to start thinking about atrial fibrillation as different diseases. And we just tend as clinicians, just because it looks the same on the ECG, to call all patients with AF patients with atrial fibrillation. And I think this just shows that the patients that undergo ablation do not benefit from a therapy where we have very strong evidence that it is very good for other patients whom we also call patients with atrial fibrillation, but who may have a different disease and that benefits from AMIOdarone. And I think moving forward, we need a clinical classification to distinguish between these patients, and we don't have it yet.
So the message is the clinical context of the atrial fibrillation may be crucial.
Yes.
I just have a quick question. So why does this just not reflect the half-life of amiodarone? And are you just putting off the inevitable? You load the patient 3 to 6 months later, the drugs run out, and we're just putting off what's going to happen anyway with these patients.
Well, you could say that, but well, the arrhythmias, the early arrhythmias following ablation is thought to have different mechanisms than, what you say, normal atrial fibrillation. It's thought to cause by mechanistical and inflammation caused by the ablation itself. So, well, this hasn't been studied that well until now.
Thank you.
Time for one more question here.
Okay, I've got a quick one and then a more involved one. Steve Stiles, theheart.org. On the results one, do you have the numbers for the endpoint difference? I know it's not significant, but...
For the placebo group, it's 52%, and for the other, it's 61%.
Thank you. And also, just to expand a little on the point made a few minutes ago, you found that there was possibly patients who had a history of longer episodes may get some benefit from this. Is that possibly related to this point about what the underlying etiology of the atrial fib is, and maybe that has an impact?
Well, that's a good point, yeah. I think so.
And is it worth exploring further in other trials? Is that a good enough finding and important enough to explore further?
Yeah, I would think so.
Okay, we continue, thank you.